Good afternoon, good evening, depending on where you're tuning in from. Welcome to our live stream today on TransMasc surgeries. We're so happy to have you join us. My name is Kathy Molig. She, her are my pronouns. I am the founder and executive director of TransFamily Support Services. We serve trans individuals and their families all across the country. Our tagline is navigation for the journey. So if we don't know how to do whatever it is you're needing help with, we certainly know who to refer you to. So we offer support groups. We offer family engagement sessions where we can talk with your family members to help them to become affirming and educated and understanding. We offer trainings. And a big piece that might be of interest today is that we offer navigating insurance when it comes to getting your health insurance to cover medical transitions. So feel free to check us out more and drop us a line if there's anything we can do to help for you in the future. There are never any fees for our services for trans individuals and their families. But today I'm super excited to get to share with you Dr. Dev Jagarla. Sorry, it takes so long to get names. He is with Align Surgical Associates, Inc. in the San Francisco Bay Area and has been working within the trans community for over 7 years. And so I am just going to turn it over so that he can dive right into all this amazing information that he's going to be sharing with us today.
Hi, Kathy. Thank you so much for the introduction. And hi, everyone. I'm Dr. Gurjala. It's a pleasure and an honor to speak with all of you. I really hope you find the presentation useful today. I'm just going to share my screen here. All right. Are we going to switch over to my screen? There we go. Great. Okay, so today I have the pleasure of speaking with all of you about masculinizing gender affirmation surgery. I come from a practice called Align Surgical Associates. Those are my surgical partners. There's 3 of us total in the group, and we're located in San Francisco, California. My background in particular is that I did all my training at Northwestern in Chicago, and then I did a microsurgery fellowship at Stanford. I also have a degree in engineering, and I don't know, that might come across a little bit in my presentation here, but I really find it useful to think about things in terms of design and engineering and bring those ideas to surgery. So what I'd like to talk about today is just giving you a broad overview of masculinizing surgery. So this will be chest surgery, also called top surgery, and the different types of bottom surgery, as well as body contouring. And then at the end, the last 15 minutes or so, we'll have a period for question and answers. So I'm just going to dive right in. And a few words about all of you, our patients. I think just a very simple way of thinking about gender dysphoria is simply a disharmony between brain and body. And when we look at the actual numbers of patients just like you out there, it's important to know you're not alone. Just in the US alone, they're estimated to be 1.4 million adults. So it is a lot of people. And unfortunately, among this group, there is a lot of suffering, high rates of depression, suicide, and assault. And so, I kind of view my job as a surgeon to help all of you not be thinking about things like basic security and physiology and how your body works, and really trying to get you up towards the higher levels of life, thinking about self-actualization and being healthy and making the best of yourself and being have less gender dysphoria to be worrying about in your life. So that's really the goal of surgery. It's not the surgery itself. It's how you can live your life afterwards. So this is a sculpture which I really love. It's the self-made person. It's literally a figure carving himself or herself or theirselves out of stone. And I kind of view myself and my colleagues as just the hammer and the chisel, but we are your instruments to use to make your body the way you want it to be. So let's talk about the masculinizing procedures. The procedures we're going to talk about are the ones towards the right of the screen. One important thing to note is that, of course, there are many non-binary procedures out there. And depending on how you identify and how you'd like to express with your body, the elements of both feminizing and masculinizing surgeries can be combined and tailored just for you. So that's a really important point to make. And I'll talk about that more during the presentation. So one of the first things to know about getting surgery is something called WPATH, and that's the World Professional Association for Transgender Health. And they're the organization that puts out standards or guidelines to really help ensure the safety of these types of surgeries. So, for example, for chest surgery or top surgery, the guideline is that the patients have a mental health provider provide one letter of referral. And that's very important because we rely on the mental health professionals to really understand your gender dysphoria and make sure that surgery is the right thing for you. And, as you get into bottom surgery, the guidelines become a little bit more, they ask a little bit more because these surgeries are oftentimes reversible and of course on the genital area. So, for example, one of the first steps in getting bottom surgery may be to get a hysterectomy. And so in that case, it's important to know that you'll need 2 letters from mental health providers, as well as being on 1 year of hormones continuously to make sure that the effects of the hormones have all taken place and that you're comfortable with the effects of those hormones. So same thing with phalloplasty or metoidioplasty, 2 referrals from mental health providers, 1 year of being on hormones, and then also 1 year of living in that desired gender role. So living as a male to make sure that it's the right thing for you before you get surgery. Now, when it comes to body masculinization, the guidelines are a little bit less strict. However, what's kind of important to know is that when it comes to insurance, insurance companies often have their requirements be sort of the strictest forms of the WPATH guidelines. So they may still require a letter from a mental health provider or hormones or 1 year living as a role. So that all depends on the particular insurance company. So that's something really important to find out about. That being said, in our practice, we, believe it or not, with increasing insurance coverage, almost 100% of our cases, probably 99.5% of our cases are insurance-based. So the rates of getting coverage for these types of procedures are getting increasingly successful. So I think that offers a lot of hope for the community that you can get your insurance to cover these procedures. Now, every insurance company is different, so and it all depends on your particular policy, but for example, whichever practice you're visiting, they hopefully can help you navigate the insurance companies. Okay, so let's dive into top surgery, also called chest masculinization. I think a really good way to think about this surgery is kind of having a developmental perspective on it. So what I'm showing you here is just what we call the chest wall. That's basically the muscle and bone. And if you overlay on this, this is a photograph of a patient. This is a cis female patient. I want you to keep in mind that under the skin and fat, under the outside covering, is still the same muscle and bone. Okay, so as a person goes through puberty and estrogen comes on board and leads to development of the breast, you can see that the breasts start forming under the skin, and they actually are literally stretching out the skin on top of what was the pec muscle, and they are expanding that skin. That's the reason that the female areola is bigger than the male areola. It's just because it's the male areola which has been stretched out over time. So this continues until full breast development. But what I hope you can see is that the underlying structures are still the same. So you can kind of think of the breast as a separate structure on top of the chest wall. And our job as surgeons is to remove the breast tissue that is not wanted, and then reshape the skin so that it better conforms to the pec or has whatever appearance that you want it to. For example, if it's a non-binary appearance that you might desire. So I just think having this developmental and structural understanding of the chest can be helpful. So if what you're looking to have is a masculine appearing chest, there are certain characteristics which create that appearance, and one of them is this shape down here. So it's more of a kind of a squared off shape. There's a tight inner turn, a broader outer turn, and then a portion which goes at about 45 degrees up into the armpit area. Okay, and if you look at the nipples and areolas, they are smaller and they're located lower and off to the side than the typical cis female location. So the reason for that shape is just the pec muscle. It's not rocket science at all, but this sort of guides what the skin looks like at the surface level. But it also provides a really nice landmark. So one of the techniques that's used in top surgery is called double incision surgery. And that means having an incision placed somewhere in this vicinity. And what's really nice is that you can use this muscle as a guideline or a landmark for where to place that incision. The pec always starts at the head of rib number 5 right there. And so this rib coming off at this angle is what forms that first turn that you see right there. So ideally, that's where the incision would be placed. So this is a picture of a cis male chest, and I just want to point out certain things to you. There's that shape again that we're talking about. What's really interesting is that when you look at the pec muscle, it's actually kind of narrow right there. And it looks way more narrow than things do at the level of the skin, right? So this looks wider out here. Well, the reason for that is that cis males actually have a little bit of breast tissue, and that's actually very, very important because it's actually the edge of that breast tissue that defines the width of the chest. A second thing that it does is that breast tissue gives a little bit of what we call projection, or makes the nipple come out just a little bit, and that's also really important for having a natural appearance. So this is just kind of a diagram form of something that you might aim for if you're looking to have a masculine appearing chest. So here are some examples, and I show these examples as images from Google, and my point is to kind of have you develop an eye for what to look for in top surgery, because the general sort of guideline, I think, is that top surgery is a surgery of avoiding pitfalls. So there are actually a number of things that can go not right in surgery, and so you want to really avoid those things. So these are kind of examples of that. What is often seen out there is an incision which is connected in the middle, so it goes all the way across. And I think, in my experience, I've never had to do that, so I don't recommend having that. It's really not necessary to have that long of an incision that's connected in the middle. Here's an example where the incision is just a straight line. And if you want that, that certainly can be done. However, in terms of having an appearance which might look more natural, a straight line placed on somebody's body is not the most natural appearing thing. And that's because if you look at the human body, there is no straight line. There's always some sort of a shape or a curve. Now, as opposed to straight lines, sometimes the incisions can be really arched or arced here. This one happens to be connected in the middle. And sometimes these arcs can be very pronounced. And, for some, that might be dysphoric because that's essentially the footprint of the previous breast. So if that's important to you that you don't want that, you really need to let your surgeon know. Okay. Now here's another result from Google, and it shows, a very nice masculine chest appearance. However, the nipples are located very, very low. Okay, so nipple position is something that's really important. These are off to the side overly, and so just want you to get an appreciation for that. Now here is an example where the incisions are not these large arcs, nor are they straight lines. They are trying to at least follow the shape of the pec, which is really good. I do like that. However, if you look kind of with a more subtle eye at this result and look at the light and shadow, you can see that the pec muscle is actually down there because that's shadow of the pec muscle right there. So my particular philosophy on this is that it just makes sense, I think, to try and place the incision within that shadow. With top surgery, there will always be scarring. There will always be a scar. What we want to do is get that scar to heal as nicely as possible, but we also want to try to camouflage it as best we can. So now here's an example where you can see the pec right there, but these incisions are on the low side, right? They're about 1 centimeter too low. So in the previous picture, they were too high, but these are too low. So again, just want to show you the importance of really trying to get the incision to be along the pec muscle. Now here's one where the incision placement is pretty good and it's a nice shape. However, there's all this fullness down here. And in this case, that's because there has been extra breast tissue left behind. It's basically the lower third of the breast, which was not removed. And that leads to this arc here and this fullness. All right, so this is what happens when a lot of breast tissue is left behind. This is what happens when a lot of breast tissue is taken away. In fact, too much, okay? You can get a very concave or sunken chest appearance. And remember how I talked about leaving a little bit of breast tissue right under where the nipple is going to be? This shows how important that is, because if you don't, then you can have this sunken or concave appearance. And this is very, very hard to fix. Another example of removal of a lot of breast tissue, too much breast tissue. Okay, so again, trying to aim for something that looks like this. And what I kind of want you to have in your mind is that there are many variables that go into top surgery. The ones that we just talked about, the scar shape, how it's placed, the areola, its size, its shape, the nipple size, the overall contour of the chest. All these things are really, really important. So I hope you can develop an eye for these things and then talk about them with your surgeon, whatever you might like. Okay, so getting into the techniques for top surgery, I'm sure you've all heard the term keyhole. So keyhole just means that the surgery is done through a small incision. So this is a really nice option because the scar is minimal. However, it is only for patients with an A-cup breast size or even lower. If you try to do this with a breast which is bigger, then you can have lots of loose skin or wrinkling, or not be able to take out enough breast tissue. Okay, so this is for very small breast sizes only. Now, there's a variation on this keyhole, which is called the Circum-Areolar. So the previous one is called the peri-areolar, meaning around the areola. But Circum-Areolar means all the way around the areola. So in this case, there's kind of a donut of tissue which is removed, a donut of skin, and that's so that you can decrease the surface area of the skin so that when you close that incision, it sits more tightly against the pec muscle. So this is to improve the contour and not have any loose or extra skin. But again, this is only really for A-cup size only patients. Okay. Here's some keyhole results so I can show you. So this is before, okay, and this is after. And again, I hope this gives you a sense of how small the breast has to be in order for this technique to work well. Okay. Most people, of course, have larger breast size than this. Here's another example. This one here is a peri-areolar, and this one here is a circum-areolar. So a donut of tissue is taken out and then closed to give that appearance. Here's another example. This is another circum-areolar. So that here in this case, a little bigger donut was taken out to make that skin more flat and sit right up against the pec muscle. Okay, so the most broadly used technique is called the double incision, and this just means that's because there are two incisions. And in this case, the breast and skin are directly removed, and then the incision is closed. Because the area of the breast that's removed contains the nipple and areola, that has to be put back on as what's called a free nipple graft. Okay, and we'll talk about that. This is for patients who are about a B cup or larger. Okay, And it can be anything larger. It can be C, D, E, F. It can be very large breasts that can use the double incision technique. Now, a variation on that is called the buttonhole technique. In this case, it's not a free nipple graft which is done. The nipple is actually kept attached to the chest on what's called a pedicle. Pedicle just means a blood supply. So in this case, the nipple is kept on the chest and then it's brought out through a new hole right here. And often this can lead to a nipple appearance which is really nice because it hasn't been grafted, and preservation of sensation. Little bit more sensation than with the nipple graft, although there's no guarantee that it will be the original sensation. But this is a really nice option for patients, but there is an upper limit. You know, if the breast gets too large, maybe beyond a D, then that means retaining too much breast tissue in order to achieve a flat appearance. So if you have to keep the pedicle of with a very large breast, that means retaining a lot of breast tissue, and therefore the chest cannot be as flat as you might want it to be. Okay, and then sometimes there are combination techniques of everything I've just described, and this can be the case for when a lot of the breast is sort of low on the chest and the nipple is already in a good position. You can then just excise that portion of the breast, leaving the nipple where it is. So that's kind of a hybrid approach. So here are some double incision results. So in this case, the nipples were taken off and put back on as grafts. This patient is about a 1 month out from surgery. But what I'd like to show you here, once again, is the importance of landing this incision exactly along the pec muscle. You know, in a person like this who has a very low body fat percentage, if this incision is not accurate, you'll really be able to tell, because it will, you know, if it came across here or down here, you'd be able to tell that it was not lined up with the muscle. All right, here's another patient. So up here is the before. This is a week later. Patient starts working out, building up their chest muscles, and can end up looking like this. So once again, in this particular light, you can see the sun is coming from here, casting shadows over here. Well, because these incisions are within the shadow of the pecs, you really can't see them. Okay, and here are just a few more examples. Again, trying to follow that principle of following the pec shape. And, you know, this is people of all shapes and sizes can get the surgery done and have very nice results. Okay, so a few words about non-binary chest surgery in case what you're looking for is not strictly a masculine appearing chest like this. There are many variations. So you might aim for something more like this, where the areolas are larger in diameter than the typical cis male areola size, or located a little bit more towards the center rather than out to the side. So rather than a cis male appearance, something like this. You can also, of course, change the shape of the incisions, and they can be more rounded, for example, more arced, like in some of the other pictures we saw. So, so this is an example of a patient who identified as non-binary and really wanted something that was in between and that felt natural for them. So this was based on a lot of discussion, going through a lot of pictures, and really trying to tailor the outcome for the patient. So in this case, the patient wanted those more arced incisions and areolas, which are a little bit larger than the normal male size, and a little bit more towards the center. Okay, so that's a non-binary chest. So some key takeaways for you to remember are, again, in my opinion, that top surgery is sort of one of avoiding pitfalls. You don't want to make those mistakes that I went through before in the presentation. Really talk with your surgeon about trying to place a scar along the pec muscle border if what you're going for is a masculine chest, and then placing those nipples, discuss right where you want them to be, okay? All right. In terms of preparing for top surgery, just when you talk with your surgeon, have the perspective that it's really customizable, and therefore you have a chance to really talk with your surgeon about what you're looking for in particular. Make sure that the correct procedure is selected. Again, not a keyhole for a large breast size, or not a double incision for a small breast size. And what I always recommend to my patients is that it really helps to be at the weight that you're happiest at the time that we do the operation, because that gives the surgeon the opportunity to kind of sculpt things to your body as it is when you are most happy with it, and therefore we can give you the best results. So part of that process, if you're going for masculine appearance, may be building up your pecs and your back muscles. So I really recommend doing a lot of push-ups if you want to develop those. And also developing your back muscles, because that will give the torso more of a V shape, which can look very masculine. Okay, things that we look for post-op in terms of complications. Probably the number one thing is called hematoma, and that just means bleeding under the skin. So this happens about 1% of the time, maybe even less. So it's not something to really worry about, but I do want my patients to be aware of it. If a blood vessel decides to start bleeding after the operation, it can start building up blood under the skin. And sometimes these can be very large, and you might even feel it filling up. If that ever happened, of course, let your surgeon know right away. Sometimes we have to take patients back to the operating room to stop the bleeding. Okay. Nipple grafts, when they heal, can look really scary. Most of that is actually the natural healing process, and is not so much actually because you're losing the graft. There's a lot on the internet out there about infected nipple grafts or dying nipple grafts, but the truth is that the vast majority make them just fine. It's just that the healing process itself looks really scary. You can expect there to be about a 2 to 4 week recovery. But you will not know the final results until about a year later. It takes a long time for scar to mature, for swelling to go away, and for you to know what things are really going to look like long term. Okay, so with that, I'm going to shift gears into talking about bottom surgery, and we'll just have a quick word about metoidioplasty. So, okay, so things are skipping around here. All right, sorry guys. Okay, so metoidioplasty. So metoidioplasty is a great option for masculinizing bottom surgery, and the idea basically is to be on hormones for about a year, because that will cause the clitoris to get larger in size. Once it has achieved that size and kind of reached its maximum growth, then in order to create a phallus, that clitoris can be released from its surrounding tissues and made so that it looks more like a small phallus. You have to kind of wrap skin around the bottom portion of the new phallus in order to have coverage. You can make a metoidioplasty with or without a urethra. So the urethra is the tube that you pee through. And so you can either keep the original urethra, or you can have a urethra run along the length of the phallus so that the urine comes out the tip. Okay. Anytime you try to do urethral surgeries, that does increase the complication rate, because it's very, very tricky to get that to heal in a watertight fashion. The expectation is full that a patient will have normal sensation of the new for the new phallus. It's questionable whether it can be used for penetrative intercourse down the road. Depends on the size, but most often it's kind of difficult to do that. You can also add testicular implants to give the appearance of having testes. Okay, so that is a perfectly viable option to do metoidioplasty. Now, if you are interested in phalloplasty, let me just run through that. One important perspective is that phalloplasty is not just one operation. It's actually many operations. And the reason is because you're trying to either alter or make completely new structures, many of them. So things can get complicated pretty quickly. Um, it's important to know what your goals are, so you can break them down into appearance, and these are just, is your goal to have normal male appearing genitalia? That would mean a phallus, which is a normal anatomic size, which has a glans or a head, and also a scrotum and testes. And then you can think about functional aspects. Do you want the vaginal canal to be closed? That's something that can be done. Are you looking to pee from a sitting or a standing position? So that's called sitting or standing micturition. If it's really important to you to avoid urine from a standing position, that does mean having to have a urethral lengthening. Okay. However, if you are quite okay with sitting to avoid urine, then that means no urethral lengthening and just using the natal urethra where it is. Okay. The hope is to have good sensation in the phallus, and we'll talk about that more. And then much down the road, usually about a year or two after surgery, is the choice of whether you'd want an erectile implant if you're planning to use the phallus for intercourse. Okay. So again, just like with top surgery, a nice way to think about phalloplasty is that you can sort of design your own approach to phalloplasty and your own surgical goals. So if your goal is to have a phallus, you can have that through either getting a metoidioplasty or a phalloplasty. And like I said before, if your goal is to pee from a standing position, then you can have a urethral reconstruction or not. If you don't have the urethra lengthened, then that, in the case of metoidioplasty, is just referred to as a simple meta. That just means basically releasing the clitoris so that it becomes a small phallus. That's a simple meta. And if in phalloplasty you're not getting the urethra lengthened, that is called a shaft-only phalloplasty. So I just want you to be familiar with these terms so that when you have a consultation, you can say, I would like to have a shaft-only phalloplasty if that's what you want. Now, with the vaginal canal, again, we talked about many patients want that to be closed because it's dysphoric to have that canal. But for some non-binary folks, they might want to actually have a phallus while keeping the vaginal canal open. So that is called a vagina-preserving phalloplasty, and it's something that can be done, again, for our non-binary patients. And then, again, your appearance goals. Do you want a glansplasty or creating a head for the phallus? Do you want a scrotum? And then implants, are you interested in testicular implants or having an erectile implant? All of that is totally up to you. All right. So many options, okay? And you can make, the phallus can be made in actually many, many different ways. So one way is using abdominal tissue. So if you look in your upper left, the area of abdomen right above the pubic area can be used to make a phallus, or the groin can be used in the upper right, and in the lower left, this is a patient's back that can be used. So, and then in the lower right is a patient's leg. So many different parts of the body can be used. They all have their pros and cons. The surgeries with the abdomen and groin typically have historically a very high complication rate. The surgeries which are most often used, and which I'm sure many of you have heard of, is the radial forearm or the thigh. Okay, so I'll go through how those actually work. The basic goal for the surgeon in phalloplasty is to pick up a rectangle of tissue. That rectangle of tissue is then subdivided into a larger rectangle and a smaller one. The smaller one is rolled into a cylinder, and that actually becomes the urethra. The rest of the rectangle then wraps around that, forming the shaft or the body of the phallus. So that's called a double wrap, or a tube within a tube design. So on your right is another picture of that. That first tube is urethra, then the rest of the wrap becomes the actual body of the phallus. Now, one thing about this design is that you can see there's a lot of suture there, and there are a lot of long lines and a joint that has to heal perfectly in order to stay watertight. So it's because of this that there can be a higher complication rate in phalloplasty, getting that urethra to heal in a watertight fashion. Okay. All right. So why do we need to do urethral lengthening if you want to pee from a standing position? Well, like I just showed you, the phallic urethra, or the urethra that runs along the length of the phallus, ends at the base of the phallus. But that is some distance from the natal female urethra. So you have to build a bridge that connects the two. And that bridge is called a urethral lengthening. Okay. Down the road, once the phallus is created, this is what a glandsplasty can look like, and this is what a scrotum reconstruction can look like. And then this is what an inflatable erectile prosthesis looks like. There are many different types, but this is the type that I kind of prefer using because I think there are patients are more comfortable with this and there are fewer complications. Okay, so I think it's really important for patients to understand what are the real life results. What can you realistically expect from phalloplasty? Sorry, guys, this is jumping all over the place here. So here are some typical results, and these are taken from scientific papers or from the internet. There's kind of a range of what things can look like, okay? And a lot of it depends on the technique that was used, okay? In my view, the way that phalloplasty is currently done, there are three main challenges. The first is the amount of scarring that occurs. And as you can see here, if it comes from the forearm, there's a pretty significant scar where there's kind of a step off that occurs. You can kind of see that the forearm looks thinner. And there is also a scar on the thigh. That's because you have to take a skin graft or a shaving of skin to then cover the forearm where the tissue came from to make the phallus, okay? So there are always two large scars. If you look at the next picture, that's the result of a thigh flap. And again, there's kind of a big section missing from the thigh that was used to make the phallus. And then on the right leg, or the right thigh, there is a scar from the skin graft site, okay? So there are always two scars. It has to be that way if you're using that technique. Now, with the radial forearm, there are issues that can occur. One of them is hand swelling. A lot of patients have to wear a glove to actually decrease the swelling in the post-op period. Sometimes that glove has to be worn for a very long time, maybe even the rest of your life. And so that swelling can lead to a lot of difficulties with hand mobility. The hope is that it will resolve, but it doesn't always. So that's one thing to know. Okay, so the next area of challenge number 2, in my view, is complication rates with the urethra. So these are known as fistula and stricture. Fistula just means a hole where there shouldn't be one. So to your left, that is a hole in the urethra. And obviously, it's not a good complication to have. It's very difficult to fix. And sometimes even revision procedures to fix a fistula don't work. So it can be very difficult. And if you see the complication rates there, they're pretty high. I think that a lot of patients and families have an idea that phalloplasty can have a high complication rate, but I think it is important to see the actual real numbers so that you can really judge for yourself whether this is right for you. To the right is a stricture. Again, those rates are kind of high. And that narrowing can make it very hard to urinate through the urethra. And that too has to be fixed, of course. And the third area of challenge is making a phallus that actually looks like a phallus. Sometimes it can be challenging, especially with the thigh flap, to make a phallus that is the correct length and diameter. Sometimes the phalluses can even be too big, and if the plan is to use this for intercourse, as you might imagine, that can be difficult. So it's really important to make a phallus which is actually anatomic, meaning normal anatomy. Okay, so one thing that's kind of on the horizon that we've been working on in our practice is something called single scar phalloplasty, and it's a bit of a new approach to doing phalloplasty. There are many surgeons who get excellent results using the traditional methods that I just showed you, but if you look at the literature, the complication rate is still kind of high. So this technique, single scar phalloplasty, is an attempt to reduce the complications and reduce the amount of scarring in phalloplasty. So I'll show you what that looks like real quick here. So the basic design is that we do use the thigh, and that pink area is a urethra that we're actually trying to create in the thigh first before we make a phallus from it. The way we get all the tissue available is by putting in what's called a tissue expander. So a tissue expander is basically a water balloon which will then be inflated slowly over time to stretch out that skin and create enough skin to make a phallus. So this is kind of what it looks like for the very beginning stages, where you're making that new urethra and putting in that water balloon. It gets expanded over time. Patients like this will be wearing baggy, shorts or loose clothing to deal with this bulge in their leg, which can be there for kind of a long time, a month or two. But what it allows is for a single line closure, and no doubt that scar is quite long, but at least it is not that sort of big segment or section of tissue missing from the leg. If you look at the left leg of the patient, notice that there's no skin graft site there. Okay, so over time, this goes on to heal, and this is the result about a year later. And what you can see is there's that single scar along the right thigh and the phallus, but there's no scar on the other leg, and there's no scarring on the forearms. So I just want you to know that this new technique exists. It's still very early that we're working on, but know that it's out there, and we're happy to talk about this with you to see if it might be the right fit for you. Okay. Again, comparing this newer technique to the more traditional methods with more scar. Okay, so
we have about 5 minutes.
Okay, perfect, perfect. I think we're doing well on time. So, this slide is just to remind you that there are a lot of things that go into phalloplasty, and each of these can be grouped in different ways. To me, what makes most sense is to do things in stages and make sure you heal well from each stage before you progress to the next one, because I think things can be safer that way with fewer complications. Sometimes phalloplasty is done essentially all in one operation, and I think that's asking a lot of the body to get it to heal reliably. So this is just to give the impression that the way we do this in our practice is in stages. So each color is a different stage. The whole thing takes about a year, but maybe longer if there are complications. So phalloplasty is kind of a lot. I don't mean to discourage it, but what I do want to emphasize is that you take a lot of time to prepare for it when you're thinking about having phalloplasty. So a typical sequence is to consider doing top surgery first to work on the chest. That way you will have kind of experienced what it's like to have surgery and how to heal before you take on a bigger surgery like phalloplasty. And then, as I said, if you do want the vaginal canal closed, you have to have a hysterectomy. So you might want to think about scheduling that so that it occurs before the phalloplasty and you have time to heal. So usually we want patients to have about 2 or 3 months minimum between hysterectomy and then the start of phalloplasty. There'll be some pre-op workup that's needed for phalloplasty, making sure you're healthy, in good general health, that we might need a CT scan. Bear in mind that, as I said, these procedures can span 1 to 2 years of your life, so it's quite a big commitment. That can be even longer if there are complications. All right. Okay. So it is so essential, like I said, to be well prepared. And what we hear most and what you see on the internet is people saying, "Gosh, I wish I had known what I was really getting into. They didn't tell me this, or nobody explained this to me." Really, please take a lot of time with your surgeon to discuss these things in detail. In our practice, we try very, very hard to spend a lot of time with you, guiding you through each of these stages and having you understand what things are really like, and showing you lots of pictures and lots of examples. Having phalloplasty, even preparing for it, often means multiple visits with the surgical team so that we can get to know you and make sure that this is right for you. It's really important to have a real relationship with a mental health professional, not just in name, but that you have an actual relationship, because when you need a mental health professional, you really do need one. And oftentimes you kind of think you don't, but when you go through a big surgery, it is nice to have somebody to talk to. Social support from family and friends is really important. You are not bedridden through most of this whole process. The time when the phallus is actually created, that occurs in the hospital, and that's about a 1-week stay. But outside of that, you are walking around, you're at home, you're cooking meals, you're doing regular life stuff. You're not bedridden, not by any means, but it's nice to have support from family and friends, mostly moral support. Okay. And then, as I said, phalloplasty is kind of, given its complexity, it's really important to enter the process trying to have a really flexible mindset, that we know where we want to get you, but the path that gets you there may not be super predictable. We can outline all those stages, but sometimes you have to take a little detour or a little change in plan, pivot a little bit to still get you safely to the final outcome. Okay, so bottom surgery, even if it's meta or fallow, can be pretty complex. There are multiple stages, multiple types of surgeries. We really want you to be informed, both with regard to information and also emotionally and socially, and with mental health support. So let me just say a word about body masculinization. The idea here is that we are trying to change the shape of the torso and the hips from being feminine to being more masculine. And that really has to do with the hip to waist ratio. So the more feminine body appearance will have that hourglass appearance where the hips are wider and the waists are very narrow, whereas a masculine appearance will have the hip to waist ratio be closer to 1.0. So what this basically amounts to is targeted liposuction. And what we try to do is use liposuction to remove fat from the hips and the flanks and often the thighs to create that more straight torso. And another really characteristic appearance of the male appearing buttocks is a little bit of a concavity where the gluteus muscles are. So right around here is a little dip right there. And so we try to create that using liposuction. Now, of course, there are limits to how much we can do liposuction to change the shape, because you cannot change the bony pelvis, which does make the hips a little bit wider. Okay. So here's an example, sort of an extreme example of body masculinization, but achieving that V-shaped torso and a hip to waist ratio, which is closer to 1.0. Okay. When you're preparing for body masculinization, it really helps to be at your goal weight. So if you ever wanted to lose weight, try to lose it before we do the liposuction. And like I said, you can only make the hips so narrow because once you get to bone, that bone has to stay, of course. So, okay. So with that, I think I think we covered everything. I hope that was really useful. We can start taking some questions.
Yeah, thank you so much. That was very, very helpful, having sat through several of those types of presentations. You got it very streamlined in a short period of time. I'd like to bring Ollie Zerbel on with us now. Um, Welcome, Ollie. So Ollie has been an intern with TransFamily Support Services, is a Master of Social Work student right now, and he's gonna take this as a TransMasc person to share some of the questions that we got, and we'll take it from there.
Awesome. Thank you so much. Hi. So I agree with what Kathy said. I think that presentation very streamlined and covered a lot of the information I know that I was wondering before I had surgeries that you talked about. And so thank you for doing this. I'm just going to read along some questions that we got. You talked a little bit about it, but sensitivity on nipples with chest surgery of various types. I think there are some questions about how that works and what people can expect.
Yeah, very good question. So, the most common type of top surgery done is the double incision. What that means is removing the nipple and areola, resizing it off into a smaller areolar diameter, and then placing it back on the chest as a graft. So, the taking it as a graft does sever those nerves, which means it will not have sensation as a graft. However, as it heals, it will actually heals on the chest. The nerves that are in the chest skin will actually start growing into the graft. Okay, so that happens, slowly over time. But what you can expect, what my patients most often have actually, is that the nipples are not completely numb, but they feel kind of like just the regular chest skin in the area. So again, that's because the nerves from the chest skin themselves grow into the new graft, so that the graft ends up feeling just like chest skin.
Awesome. That makes perfect sense. One of the other questions that we got was, how long do you have to stay close to the hospital? It was specifically regards to metoidioplasty, but maybe if you're able to cover all of the surgeries that you touched on, since I do know that those differ.
Yeah, it kind of depends, as I hope you can see, so much of the surgery is sort of tailored and customizable. If it's something like a simple meta where the goal is just to release the clitoris to form a phallus, but not do a urethral lengthening, that can be an outpatient procedure. So that means no time in the hospital, just day surgery and then leave the same day. But if there are attempts to make like an actual urethra along with the meta, then that can be more complicated and require a hospital stay. And then for phalloplasty, of course, it depends on the stage. In my particular practice, most of it actually is outpatient. The only inpatient part is the time when you actually create the phallus, and that requires a hospital stay, like I said, about a week. And that's that we can watch the new phallus closely to make sure it has good blood flow and that it's healing well.
So I just want to take a moment and put in here, we're based in San Diego, and we don't have surgeons in San Diego really doing these procedures. So our folks are traveling north, whether it's LA North or San Francisco North. So that's like a whole different conversation, really, of how long you're staying in the San Francisco area. And then for our folks that are across the country, there are not that many doctors providing these services. There are more and more coming on, which is great.
Yes.
But very few people want to be in the first 10 people to do those surgeries, right? And so folks who are traveling cross country, that becomes a much greater commitment to, staying close to the hospital for a month or however long, depending on those surgeries. So I just want to kind of bring that into, a lot of times I'm working with young trans folks who, their concepts of these things, we just want to make sure that they have full picture of what's going to be expected.
Exactly. So that's an excellent point. And, as you suggested, in our practice, we have a lot of patients coming in from out of town. So many people flying in from all over the country. And so it's a very common scenario. Just kind of a quick rule of thumb is that if it's outpatient surgery, generally that means, like I said, you fly in, the next day or two you have the surgery. And then you go home. Home in this case would be like a hotel or a friend or Airbnb. And you stay for about a week because usually your first post-op appointment is 1 week out, and that's to check for healing. But then after that, you can go home. So outpatient procedures very commonly mean staying in town for about 7, 8, 9 days, thereabouts. If it's a more complicated surgery, again, like phalloplasty, then just talk with your surgeon and find out what their particular protocol is. That can mean staying in town for on the order of months, like Kathy was saying.
It sounds like there's a common thread of a lot of preparation and a lot of questions for sure. One of the other questions was, have you done any metoidioplasties on men of color? And for those that keloid, how do you minimize potential risk with any form of bottom surgery?
Yeah. So keloiding is a really big concern. Just to comment about the word keloid. Keloid, I think, is often used in place of a more accurate term, and that more accurate term is actually hypertrophic scar. So hypertrophic is just a fancy word for overgrown. And when a scar becomes thickened or raised, that's called a hypertrophic scar. I think that's what a lot of people are visualizing when they say keloid. Keloid is actually a whole different thing. That's actually akin to a skin tumor that can grow to the size, oftentimes it happens in ear piercings, and it can grow to the size of a grape or a plum or an orange. So it's a very different thing from a hypertrophic scar. So, but to talk about that, a key thing to know is that hypertrophic scars have certain areas of the body where they occur more commonly. Same thing with keloids. And those tend to be places like the ear or the shoulder right here, or the chest right here. Okay. And for these areas, at least, those are known as areas of high skin tension. For them to form on other parts of the body is more rare. So on the face, there's almost always, it's very rare to see a hypertrophic scar. Same thing in the genital area. The face and the genital area heal really well, and the incidence of hypertrophic scar is much, much lower there. So I hope that can ease some people's concerns about scarring in those areas, because frankly, you don't see it very much, if at all.
Yeah, absolutely. I think that certainly helps with, as we were talking about, so many incisions and so much scar space. Mm-hmm. So knowing that for sure. And the last one is metoidioplasty seems so much safer than phalloplasty, with dramatically less complications, as you talked about. Realizing that there's inherent risk with all of it. But how can one educate themselves enough, besides a talk like this, to feel less anxious and more enthusiastic about a procedure like that?
Yeah. Well, it's a tricky question, because it's so important to get real and good information. And it's tough that the internet is not always reliable, or I think more accurately, the issue with the internet is that it's without context, right? So you're only getting a tiny slice of the actual picture. Just as a quick aside for metoidioplasty, I didn't mention it, but if you get a urethral lengthening, the complication rates are still pretty high. They're about 25% for a fistula or stricture. Okay, so it's not like it's so much less than fallow, but there is less surgery involved. That is true. So in that way, it's simpler. Okay, but in terms of getting information, I know that it can be hard, and it's kind of easy to say this, but what I would suggest is really just having a consultation with a surgeon, and that will be your best source of direct information. And hopefully that surgeon will take the time to talk with you and really explain these things, or go through. So the presentation I showed you is actually what I show during all my consultations to my patients. So I really think having consultation is kind of the best source for information, and in a way putting things in context. Now, even beyond that, what I tell all my patients is that I do recommend that you have multiple consultations. So, I don't mind. I want you to see other surgeons so that you get more information and really educate yourself and see a variety of perspectives, and then decide what makes most sense for you, or who you feel most comfortable with.
I am so glad to hear you say that. That is a key in our navigation with folks, is to always meet with multiple surgeons. I always recommend 3, because not every surgeon is going to be the right person for everyone. And you know, gosh, you certainly get a much broader education yourself as to all the choices that are out there when you are having these consults with all the different surgeons. And just a point, if your insurance does cover your care, trans care, they will cover 3 consults. And so I think that's a really important thing to know, that you're not like using up your benefits or anything by having that.
Yeah,
but that education being so wide, and you know, for folks that are in California, for folks that have access to multiple surgeons, that's great. For folks that, you know, have to work a lot harder to go beyond 1 or 2 surgeons, it's well worth the investment from the feedback we're getting from clients.
Yeah, and especially with Zoom meetings now, it's a little bit easier. So so it can really be done. You know, sometimes it takes a while to get the appointments, and you know, we're always sorry for that, but I think it's worth it to try and get several consults.
So you all are doing virtual consults?
Yes. In fact, most of them are now. Mm-hmm.
Yeah. All right. Well, we are right about at time. So thank you, Doctor. Thank you, Ollie, very much for joining us, and thank you everyone for joining us. Those of you that are watching after the live stream on YouTube or Facebook, I really encourage you that if this is something that you're looking into, to check out websites first of doctors. Really comb those websites. I know Align Surgical Associates has great information on their site, and that educational piece will come in so handy for you as you're making all of these choices and decisions that are in front of you. The more knowledge, the easier those choices become. So, and I encourage you to join us next Saturday, same time, same place, as we do TransFem surgeries with Dr. Satterwhite, also from Align Surgical Associates, and we are here to help you in any way. Please feel free to reach out to us, reach out to the docs at Align Surgical, and we wish you all the best in your gender journey.
Thanks everyone so much.
Thank you.
Take care.